Through innovation, academic excellence, and family-centered clinical care, Children's Mercy Kansas City is transforming outcomes for children around the world. Welcome to the audio interview series, Transformational Pediatrics, with host Dr. Michael Smith.
Our topic today is thermal laser ablation. My guest is Dr. Christian Kaufman. Dr. Kaufman is a pediatric neurosurgeon with Children's Mercy Kansas City, and he's an assistant professor of pediatric surgery at the University of Missouri Kansas City School of Medicine. Dr. Kaufman, welcome to the show.
Thank you.
So let's just start off real simple question, right? What exactly is thermal laser ablation?
Well, what we usually call stereotactic laser or thermal ablation is essentially a technique wherein we can access small structures in the brain, either deep or superficial, apply a laser current that heats the tissue and essentially causes cell death in the region that is heated, thereby destroying the tissue.
Right, and now this is obviously MRI guided, correct?
This is guided directly in the MRI. So the key is, as opposed to older, we say stereotactic techniques, we see what's going on exactly while it's happening. We see it live, as opposed to older techniques where they would use radio frequency ablations or radiation ablations. Those techniques destroy the cells, but it's kind of some guesswork involved because at those times when those techniques are used, you don't know exactly how much tissue damage is occurring. So what makes...
So that's it. Yeah, so just to review that real quick, so being able to visualize basically exactly the results when it's happening,
yes,
obviously that's a huge benefit, right?
Huge benefit because again, we're often talking about deep critical structures in the brain, and seeing that live thermal map that shows exactly the area of tissue involvement is fundamentally extremely important. And it vastly increases the safety and accuracy of what we can do with it.
So who's the key candidate for this procedure?
Essentially, it was primarily, at least initially, intended for use in targeting small, deep tumors. So patients who have small, deep tumors often. To get there surgically from a traditional open surgery requires a large exposure, we say craniotomy, requires moving the brain, healthy brain, in a way that could cause damage to that tissue. And by instead targeting it through a very small tube and getting down with minimal adjustment to the brain allows for kind of an ideal situation where you don't disturb the healthy brain and only target specifically the deep abnormal tissue. So again, patients with deep, somewhat smaller tumors are ideal candidates, but we've also found that certain patients who have certain forms of epilepsy, that is, arise from deep structures in the brain, also benefit greatly from having that tissue, that abnormal tissue, damaged intentionally with the thermal ablation, and it helps significantly improve their seizure control.
So let's look at it from a patient perspective. What is it like for them in preparing for this, the actual procedure? How quick do they get out of the hospital? Run us through what it's like for the patient.
Again, it helps to understand what the traditional way of approaching many of these things is. If you look at a traditional open craniotomy for, say, epilepsy, oftentimes it requires up to 2 surgeries or more to implant electrodes, to map cortical areas, to find targets. Those are situations where families are spending up to 3 to 4 days in intensive care units, sometimes longer, with 7 to 8 day hospital stays. In comparison with a targeted thermal ablation, patients come in for their procedure. It's performed in the magnetic resonance image room, the MRI room. Because it's such a small hole, we are able to close it successfully using usually only 1 to 2 small sutures, and they go home the next day. So we're changing a potentially week-long stay, including intensive care unit stays, into a one-day stay without ICU
Right.
stay.
So benefits to not just you as a clinician. You're able to target what you want. You see the results you want. There's better results, and it's better for the patient all the way around. So this is a very positive thing.
Yes.
Well, why don't we do this? Let's share a little bit of some of your experience using thermal laser ablation and some of the outcomes you've experienced in your practice and at Children's Mercy. So just talk a little bit about the outcome you see.
So far, when we talk about use of the thermal ablation system, again, in epilepsy surgery, again, a traditional epilepsy surgery is a long stay in the hospital. Although the traditional open approach we know is very successful and it works great for properly selected patients and they have very good seizure control outcomes, we are getting comparable results with thermal ablation. Is it quite as good? No. Whereas we can have excellent seizure control rates in about 80 to 85% of the time with open surgery. With thermal ablation, those numbers are reduced to, say, perhaps 60, 65% of the time. However, in doing so, the complication risk for the thermal ablation is dramatically smaller. The risk to the patient is smaller. And if for some reason that technique doesn't work, then we can always still do the traditional surgery. So we don't burn any bridges, so to speak, surgically, or we don't burn any options for the patients, no pun intended, when we do the thermal ablations. So it's a technique we can use. If it's successful, great. It's relatively low risk, which is also great. It's a short hospital stay. All the things that are highly desirable. And then so far, as of now, we have not, for our epilepsy patients, we have not yet had to do an open surgery due to essentially a complete failure of the technique. So that's also been great so far.
Right. Well,
in regards
where do you think this? No, go ahead.
Yep. In regards to the tumor patients we've had, again, the most recent patient we had a relatively or significantly deep tumor surrounded by some very challenging blood vessels that to do an open procedure would have been essentially dangerous, would have been a very high-risk procedure, could have caused significant stroke or damage to the brain. We were able to successfully navigate between those vessels with the stereotactic laser and completely ablate the entire tumor tissue, and again was able to go home within a day without any damage to the surrounding brain tissue.
So where do you think the future of stereotactic laser ablation is? I mean, where do you see this going in future applications?
Well, already we're seeing, both at our institution and around the country, we're seeing a dramatic, almost exponential number of cases being performed. Neurosurgeons, both adult and pediatric neurosurgeons, are recognizing this technology immediately for the huge boon that it is. And I think we're going to see a dramatic increase in the number of applications for it just because it's so low risk, because it offers a lower complication rate, and again, typically comparable results without destroying options for more open techniques. I think it's going to become a frontline kind of go-to procedure for many intracranial pathologies instead of jumping ahead to the bigger surgeries.
From the surgeon's perspective, what kind of extra training do they go through for this? Pretty extensive. What did you have to go through to be an expert in this procedure?
Typically, all neurosurgeons, or not typically, all neurosurgeons are trained by virtue of the training to do what we call stereotaxy, which is, again, targeting small areas of the brain through small incisions. It's one of the oldest techniques in all of neurosurgery. It's over 100 years old. Traditionally, it was done with a frame where a metal frame was actually bolted to a patient's skull, as kind of medieval as that sounds, but it allowed for very specific accuracy through a small hole. In the past about 20 years, through technological advances, we've been able to do what we call frameless stereotaxy. So through the aid of MRIs and CT scans, we're able to achieve the same sort of results through small holes without having to bolt a frame to someone's skull. So frameless stereotaxy is kind of part and parcel of every neurosurgeon's training. So essentially, the only difference between this is it's a kind of a technology thing. Instead of passing an electrode or any other device, biopsy needle, what have you, we're just passing a thermal catheter. So from a procedural standpoint, it's still the same as many other stereotactic procedures. It's now we have a new technology that we can apply these surgical techniques to and use the newer technology to achieve these results.
Right. Well, Dr. Kaufman, I want to thank you for the work that you're doing. I want to thank you for coming on the show. You're listening to Transformational Pediatrics with Children's Mercy, Kansas City. For more information, you go to childrensmercy.org. That's childrensmercy.org. I'm Dr. Michael Smith. Thanks for listening.